Bismillahirrahmanirrahim. Our presentation today about pelvic fractures. Objectives of the lectures include incidents, to understand the pathology of the pelvic fractures, and to assess and how to work up the trauma patients for pelvic fractures, treatment of the unstable pelvic fractures, and lastly complications. First of all, about the epidemiology, fractures pelvis represents about 4% of the whole skeletal fractures. It represents about 42% of the road traffic accident injuries, and it occurs mostly in about 25% of polytrauma patients. So any patients with pelvic fractures must be considered as polytrauma patient until otherwise. Commonly, fractured pelvis is associated with the other injuries. So these patients is commonly polytraumatized patients, and this includes chest injury in about 60% of cases, CNS in about 40%, gastrointestinal injuries in about 30%, and genitourinary injury in 25% of cases. The mortality rate in case of the unstable pelvic fracture is relatively high. It reaches about 20% in case of the closed fractures and about 50% in open fractures. The commonest cause of the death in case of the unstable fractured pelvis is blood loss. And the sources of the blood loss in unstable pelvic fractures include fractured bone surface, pelvic venous plexus, pelvic arterial injury, and up to 30% of the extra pelvic sources like chest or abdomen or multiple extremity or external sources of bleeding. The pelvis acts as a ring, which consists of the two hip bones and the sacrum, and it contains multiple important neurovascular structures passing through it, and multiple important organs. The stability of the pelvic ring depends mainly on the ligaments attached to the pelvis, like pelvic floor ligaments, like sacrotuberous and sacrospinous ligaments, symphysis pubis, and sacroiliac complex. Disruption of the ring at one side, whether anterior or posterior, commonly results in stable fracture pelvis. But if this ring is disrupted at two sides, like anterior and posterior, or on both sides, this is unstable fracture. So this represents disruption of the ring in anterior and posterior part. This represents unstable of this ring or unstable of the pelvic ring. Again, the stability of the pelvis depends mainly on the ligaments, like pelvic ligaments floor, like sacrotuberous and sacrospinous ligaments. Again, this is the sacrotuberous and sacrospinous ligaments. Symphysis pubis. The best classifications of the pelvic injuries depends mainly on the severity of the lesions and basis of the treatment on the severity of the lesion or the direction of the forces acting on the pelvis. This example of one of the commonest classification system for the pelvic ring fractures, which is called the tile classification, which is classify the fractures into type A, B, and C. Type A is a stable fracture. Again, it represents disruption of the ring at one side. Type B is rotational unstable but vertically stable fractures. And in type B, there is what we call open fracture pelvis, when we can find the distance between at the symphysis pubis more than 4 cm, and this commonly represents the disruption of the ring anteriorly and posteriorly, and sometimes with the pelvic floor ligaments injury. Lastly, according to the tile classification, there is what we call vertically and rotationally unstable fracture, which is type C. Again, there is another classification for the pelvic fracture, which is include Yang classification, which classify the fractures according to the forces acting on the pelvis, lateral compression force, or anteroposterior compression force, or vertical shear. This represents the lateral compression force, which can be classified into three types, type 1, 2, and 3. In type 1, there is sacral compression fractures at one side of the site of the impaction. In type 2, there is iliac wing fracture at the site of the impaction. In type 3, the same as type 1 but associated with the contralateral anteroposterior compression fractures of the symphysis pubis. According to Yang classification, anteroposterior compression include again type 1, 2, and 3. Type 2 represents open poke pelvis, which is again unstable fractures rotationally, but it is stable vertically. And lastly, according to the Yang classification, there is vertical chair, which is rotational and vertically unstable fractures. This example of the vertical chair fractures at the left side, of course, we can find this is unstable fractures. How we can manage these patients of the unstable pelvic fractures? First, we must do resuscitation of the patients according to the Advanced Trauma Life Support ATLS principles. Then, we must assess these patients clinically, including leg length discrepancy or the rotational deformity without fracture, suggest unstable pelvic fractures. Motion, which is maybe detected by grasping the iliac crest and pushing inwards then outwards. Inspections for the flanks, scrotum, perineal area for the bleeding, including urethral meatus. Inspect for any laceration in the perineum, vagina, rectum, or buttocks for open pelvic fractures. And then palpate for high-riding prostate glands in case of need. Local examination also include assessment of the skin manifestation of the subcutaneous bleeding like Gray-Turner syndrome or moral love lesions, perineal wounds or laceration, urinary and rectal examination as we described before. This example of moral love lesions and Gray-Turner lesions. As regard the assessment of the pelvic stability, we must assess the pelvic stability whether rotational and vertical, measurements of the length, then go for radiological evaluations. According to the ATLS, these patients we must do fast pelvic abdominal ultrasound, lateral view of the cervical spine, posterior anterior view of the chest, and lateral view of the lumbar spine. This is the pelvic inlet view, anteroposterior view for the pelvis, pelvic inlet with caudal inclinations of the tube of the radiology, and pelvic outlet views. So the anteroposterior X-ray of the pelvis confirmed our clinical examination. FAST is very important and specific input for detection of the intra-abdominal injury, but not commonly for the retroperitoneal bleeding. If the FAST is positive, we must go either for laparotomy, or if it is negative, we need CT pelvic abdomen. We do CT in hemodynamically stable patients for clinical suspicion of the intra-abdominal injury, and sometimes we need retrograde urethrogram in case of the severe pelvic trauma for assessment of the inurethral injury. How we can treat these patients with unstable pelvic fractures? First, as we described before, resuscitation of the patients according to the ATLS protocol, urgent stabilization of the pelvis, and permanent stabilization of the pelvis. What about pelvic stabilizations? The goals of the pelvic stabilization is to reduce the pelvic volume to decrease the hemorrhage, some sort like earlier tamponade. And this can be done whether by wrapping a sheet around the greater trochanters and tighten it down, or commercially available pelvic splint or pelvic strap, or external fixation of the pelvis. So again, urgent stabilization include external fixation or C-clamps or slings. This example of the pelvic stabilization using certain straps around the pelvis. This is the X-ray of these patients before we apply this sling, and this is the view after applying this sling. This represents how the size of the pelvis decreases, and so there is tamponating of the source of the hemorrhage. This example of the commercially available pelvic binder, and this example of what we do external fixator or C-clamp for compression of the pelvis, again for tamponating the lesions or decrease the size of the pelvis to decrease the sources of the hemorrhage. So we can decrease the space in which the retroperitoneal space in which the blood can accumulate. These examples of how we can put the C-clamp urgently and rapidly in case of the unstable fractured pelvis. We do marks on the skin. We apply the C-clamp at the greater trochanter or the anterior superior iliac spine, and then we can reduce it. After urgent stabilizations and when the patient is hemodynamically stable, we can do definitive management or final stabilization of these fractures, whatever the method of the stabilization. For example, we can apply plates anteriorly for the symphysis pubis, or fixation of the sacroiliac disruption, whether with screws or plates. Now we are going for the complication of the pelvic fractures, which is include infection in about 25%, thromboembolic complications, malunion, non-union, and myositis efficans. So lastly, we can say there is important facts. Any patient with the unstable pelvic fracture must be considered as polytrauma patient until proved otherwise. Hemorrhage is the main source of shock and the main cause of the shock in case of the polytrauma patient. Urgent pelvic stabilizations may be a life-saving procedure in case of the hemodynamically unstable patients. Thank you.